So minimal residual disease is a very useful and prognostically powerful surrogate for the depth of the remission after the end of treatment. It's a little bit different than all other biomarkers that we discussed, because it's not something that we can use for prognostication up front before starting therapy. So we can only use the MRD status, of course, as an indication of the depth of the remission after a certain treatment exposure. But even in this situation, it allows us to understand whether or not the patient has sufficiently responded to therapy. And at the moment, it's just a prognostic marker, meaning that if a patient still has certain levels of residual disease, we can assume that the patient will relapse earlier than a patient who has very deep remissions or even undetectable disease. So in that sense, it's a strong prognostic biomarker. In terms of prediction, though, we still do not know whether we can, based on an MRD positive status, whether we can design any treatment interventions that are of benefit for the patient in the long run. So the key question at the moment is whether a patient that remains MRD positive after 1 year, for instance, of venetoclax-based therapy, whether this patient would benefit from extending or intensifying or consolidating further beyond the first year of treatment. And this is a question that can only be really answered with a randomization. So randomizing an MRD-guided approach to a non-MRD-guided approach, for instance, to a fixed duration approach, really to understand whether there are any patient-relevant benefits of extending therapy, or whether the conventional fixed duration approach that we've been using for decades with chemomonotherapy, whether this approach is sufficient for most patients. So still a few open questions, but I think efforts are ongoing to answer these questions.